Morning. Our objectives for this lecture are know the most commonly encountered bone sarcomas, their characteristics, and treatment. Towards the end, we will touch on metastatic bone disease. So if we deal with bone sarcomas, you should be able to know first your Anakin staging. This is the most commonly used staging in bone sarcomas, primary bone sarcomas. If we have grade 1 refers to a low grade, T1 refers to a intracompartmental, occupies only one compartment. While grade 2 refers to a high grade, and T2 refers to extracompartmental. Systemic bone diseases like ground cell tumors, for example, you have Ewing's, multiple myeloma, lymphoma, and others. This Anakin staging is not applicable to them. So you memorize this, you familiarize yourself with Anakin staging, and apply it to your patients. Another way of applying bone sarcoma staging is according to the American Joint Committee on Cancer System, or the AJCCS. But most commonly, the Anakin staging is used. Here in the AJCCS, 1 is low grade, 2 is high grade. You also take note of the size, where 8 centimeters is the cutoff. Histological differentiation of bone and soft tissue sarcomas. High grade, usually this is poorly differentiated. Usually it's fastest growing and aggressive, and defined as the tumor cells do not look at all like the normal cells. For intermediate grade, this is moderately differentiated, grows faster than the normal cells. The tumor cells do not look like the normal cells. And we have low grade. Low grade is a well differentiated and they are slow growing lesions. The tumor cells look a lot like the normal cells. Somehow, there is a resemblance to normal cells. Let us go to marginal treatments of tumors most commonly used. We have intralesional, where 1 goes into the tumor. Usually, the common term used are debulking and curettage. So if you do debulking and curettage, you're actually doing an intralesional margin. We have marginal. If you do a resection within the pseudocapsule or the reactive zone. Reactive means there are presence of inflammatory markers. For wide resection, you resection plus normal calf or soft tissue and bone. For radical, is defined as resection plus 1 compartment. For example, if you have a lesion on the tibia and you need an above the knee amputation, that is radical. Or if you have a lesion on your proximal vastus lateralis muscle and you resected the entire vastus lateralis, that is also radical. A quick reference guide for your margins for better understanding. Osteosarcomas are 20% of all the primary malignant bone tumors. A majority of these osteosarcomas are high grade, and they are conventional, 10% of which can be secondary. There are different types of osteosarcomas according to its histology. We have the very common one, we have osteoblastic type. The rest will be fibroblastic, chondroblastic, telangiectatic, and the small cell type osteosarcomas. Remember, all osteosarcomas are radioresistant. An X-ray of a typical osteosarcomas, we have a large epimetaphyseal, both central and eccentric in location, in the proximal tibia. You have your periosteal reaction, what we call sunbursts, on the lateral tibial plateau, plus a cortical break with soft tissue, and with osteoid matrix. This is anything stage 2B or AGCC 2B. Take note there are no skip mets noted on the MRI. It is very essential to request for the whole extremity MRI to know if there are skip lesions. You may notice this as a small lesion beyond the primary location. So it's very important for you to have not only the MRI of the lesion, but the whole extremity. In its histology, there is noted osteoid deposition in a lace-like arrangement. This one, okay? A typical appearance of an osteoid distribution in osteosarcomas. Others, we have presence of different stages of mitosis, and others are hypercellularity. After history and PE, you do your clinical evaluation of your X-ray. And if you think it is very aggressive and entertaining a possible malignancy because of its faster doubling time, the reaction of your periosteum against the lesion, you do at least a CT scan or better MRI prior in doing your biopsy. I have another lecture on biopsy. You may refer to that. For metastatic or non-metastatic osteosarcomas, we usually use neoadjuvant chemotherapy as much as possible. After such chemo course, surgery will include metastasectomy if metastatic osteosarcoma and possible limb salvage versus amputation. Sometimes we encounter patients referred to us with tumor bleed. It may be an indication for us to do upfront ablation, and this is justified. This is somehow have a goal to preserve the life more than the limb. After surgery, the patient again will undergo adjuvant chemotherapy, then followed by surveillance. Osteosarcoma may come in different appearance in your radiographs. Okay? It might appear as like this is in the distal femur, proximal tibia. Although it is not characteristics of being an osteosarcoma, it may seldom appear as this one as we notice in the shaft or the diaphysis of your femur. An example of a wide resection of an osteosarcoma of the distal femur and shaft of the femur. The difference is for the shaft, we had a joint sparing in this patient. We have in general two types of limb sparing resections. We commonly use extra-articular and intra-articular. Intra-articular resections are the ones we are actually doing for our limb salvage. We go inside the joint, fashion our cut to resect and block our lesion, while extra-articular is we go outside the joint. Both of these resections shown are intra-articular. Both patients underwent limb sparing surgery using tumor prosthesis. There are other variants of osteosarcomas. These are your surface osteosarcoma. It's about 3 to 5%. And the most common of these surface osteosarcomas are your parosteal osteosarcomas. It affects female more than male in their second to third decade of life. It is 1 to 6% of all cases of osteosarcomas. The behavior of parosteal is generally low grade. Commonly, these are painless and therefore sometimes patients who has these does not consult, and the lesion may extend into the cortex and penetrate the medullary cavity. However, medullary involvement does not connote poor prognosis. An example of a parosteal osteosarcoma, this one. It is usually dense centrally, no intramedullary extension in early cases, commonly at the back of the knee and at the posterior femur. Your second picture is myositis ossificans. The third picture is obviously your osteochondroma. Take note that majority of the components of its histology are cartilage, located on the surface of the tumor. There are also findings that they have chromosomal amplification. Because they are low grade, wide resection surgery is enough. No need for chemotherapy or radiation. Second of the surface osteosarcomas is known as the periosteal osteosarcoma. This lesion affects equally male and female in the second to third decade. Most commonly affected is the diaphysis of the femur or tibia. The distinct behavior of this lesion is that they behave as having an intermediate grade. A sample radiograph of a periosteal osteosarcoma. Notice the bony spicules projecting away from the cortex. This one. They are less dense than parosteal osteosarcoma. There is always involvement of the medullary canal. As they behave as intermediate grade, the treatment is the same as the conventional osteosarcoma. If you look at the MRI, you notice how extensive it is. Chondrosarcoma. It affects more male than female. It can be primary or arising from other pathologies as secondary. They are slow growing and shows you malignant cells with abundant cartilaginous look in its histology. Chondrosarcomas, remember chondrosarcomas are chemo and radiation resistant. Hence, surgery is the mainstay of treatment. Previously diagnosed enchondroma patient. Through times, the lesion went into different behavior. You notice an osteolysis around medial and supero-posterior area. This one, medial and supero-posterior area. A cortical break posteriorly with lesion going outside. As you look at the MRI, this one, there's a cortical break here. Obviously, the lesion got out, going to the posterior. You note also the CT scan. Okay, it seems that the cortex here is intact, but if we see the MR, obviously there is breakage of cortex. Now we go to round cell tumors. These tumors are systemic in nature. This group of neoplasms are characterized by small, round, relatively undifferentiated cells. Differential diagnosis of small round cell tumors are particularly difficult due to their undifferentiated or primitive character. Tumors that show good differentiation are generally easy to diagnose, but identification of the diagnostic morphological features are difficult when the tumor is poorly differentiated. Therefore, no definite diagnosis may be possible. Generally, the treatment, chemo and radiation, because they are very responsive to such treatment protocol. A sample case of Ewing sarcoma. on the proximal tibia to its diaphysis. You may observe in some cases an onion peeling periosteal reaction on the X-ray, wherein your periosteum are peeled just like a characteristic of an onion. Ewing sarcoma affects male more than the female, 10 to 20 years old. If your patient is 20 years old, you may entertain more of a possible case of lymphoma, more common than Hodgkin's lymphoma. Clinical features for round cell tumors are the same for all. You may have constitutional signs and symptoms. Histology of Ewing sarcoma shows as the rosette or show the rosette's appearance. They are usually positive on CD99 immunohistochemistry. Now we have plasmacytoma or multiple myeloma. Most common primary malignant tumor in the 6th, 7th decade of life, equally affecting both sexes. If you have only one lesion, then it is plasmacytoma. You will have the clock phase nuclei, characteristics of plasma cells. This one. It's pushed to the side. In clock phase. This one. These are plasma cells. The pathophysiology of myeloma are, if you have multiple myeloma, you will have a multiple lytic lesions due to hypercalcemia. You will have hypercalcemia because there is an increased osteoclastic activity causing an excess production of calcium. So automatically it causes your hypercalcemia. In patients with multiple myeloma, you will have renal failure eventually. This is because of the kidney tubular damage inflicted by the free light chains. You will also have anemia. This is brought by the overgrowth of plasma cells than the RBC. Together with biopsy-proven lesion, hematologists also do bone marrow aspirate. To diagnose a multiple myeloma is you need a one major criterion and one minor criterion or three minor criteria. What are those criteria? Will be your further readings. Multiple small diaphyseal lytic centrally located lesions. These are moth-eaten borders and moth-eaten appearance. No periosteal reaction, no cortical break, no soft tissue, or no matrix. Usually for your skull X-ray, you will have a punch-out lesions. Sample case of multiple myeloma, but if you have this punch-out lesion, it is not pathognomonic that the patient automatically has multiple myeloma. There are other diseases that will show you punch-out lesions in your skull. Now we go to metastatic bone disease. Metastatic bone disease occurs through hematogenous dissemination, very commonly, seldom through direct extension or lymphatics. Most common location of your metastatic bone disease are your actual skeleton, meaning your ribs and your vertebrae. This commonly is your acral metastasis, meaning if you have acral metastasis, the lesions distal to your elbows or knees. If you have this, they say theoretically, if you have acral metastasis, most common, it came from your lung CA. You have different extra appearance of your metastatic bone disease. For example, if you have a breast mets, usually your extra appearance shall look like shall be mixed. You will have both lytic and blastic. For your prostate, you have purely blastic. For your thyroid, lytic. Renal, lytic. lungs mix. For your GI, cervical, you will have lytic. An example of your radiograph for your spine is a very common site of metastasis. Take note of the winking owl sign. It means you have an absent pedicle sign. You may refer to this X-ray. It's your pedicle. Obviously, your pedicle on the other side is absent. Okay. Note also on the other X-ray. Note the absence of both pedicles at L2 and at L5. This is often called the blind vertebra. You don't have any more pedicles, bilateral. If you have metastatic bone disease, we usually use the Merrell's scoring. Use of Merrell scoring in metastatic bone disease is a time-tested scoring where the clinician scores the patient for a possible prophylactic fixation. So you have four criteria: your site, your pain, lesion, size. Your scoring will be or shall be 1, 2, 3, and take note of the location, the site, upper limb, lower limb, per stroke, the pain, mild, moderate, functional, etc. If you have a score of less than 7, usually we do not recommend surgery. Otherwise, if more than 7, we recommend prophylactic fixation. As mentioned, the most common sites of metastatic bone disease is your axial. It is a must know now for you to know these Tomita surgical types. It is in your Rothman spine book. We have type 1, 2, 3. Okay. 1, 2, 3 under intracompartmental. 4, 5, 6 under extracompartmental. 7 shall be under your multiple. Okay. Treatment principle in general for metastasis. Know the primary source. Biopsy the most accessible lesion. Know your Merrells. Determine your spinal instability. And do your chemo or radiation if it's sensitive. Thank you.